And thank you for joining us. I'm John Simoes with Protect Our Care New Hampshire. This April is the ninth annual Medicaid Awareness Month, and we're going to talk about what's happening right here, what's at stake for healthcare across New Hampshire. Medicaid covers more than 180,000 Granite Staters. It supports children, seniors, people with disabilities, working families, and it plays a crucial role in keeping our hospitals, our community health centers, long-term care providers, all these folks operating, especially but not limited to rural parts of our state. At the same time, we're seeing growing pressure. Proposed federal funding cuts, rising costs, and workforce shortages are all converging right now, and the impact is being felt in communities across the state, from cities to small towns. Today, we're joined by three experts who bring policy, provider, and legal perspectives to this conversation. I want to welcome, first of all, Dr. Marie Ramas, who is president of the New Hampshire Medical Society, Deb Fournier, who is the director of health law and policy at the Institute for Health Policy and Practice at the University of New Hampshire, and Sam Burgess with New Futures. Of course, New Futures is a New Hampshire organization focused on advancing public health and public policy. Thank you all for being here. It's a pleasure. Deb, I'd like to start with you. Can you give us an overview of where we are right now in New Hampshire with Medicaid, and specifically, the federal funding pressure that are
Mm,
increasing on our clinics and our hospital? Which populations or services who are right now feeling the impact? Give us an overview of what's going on.
sure. Right now, in New Hampshire Medicaid, as Jaime said, we cover about 176, 180,000 people. Um, and in general, there are some changes that are coming to Medicaid from the federal level um, that are going to put a lot of enrollment frustration pressure on low-income adults. So they're often referred to as the Granite Advantage adults or the expansion adults. There's about 52,000 of them at any given time in New Hampshire. And because of federal changes that were enacted over the summer, there was a big bill that it's called HR1 or the One Big Beautiful Bill Act. Took out about almost $1 trillion across the country in Medicaid funding. And it does that through a number of things, primarily through applying work requirements to the expansion population so that people have to demonstrate a certain amount of particular activities to keep their Medicaid coverage. It doubles eligibility checks. So right now, eligibility checks are once every 12 months. And for this group of people, it will become twice a year, excuse me, once every 6 months. And then there will be some financial impacts. Also, people will be required because of some state budget changes to pay premiums and then eventually to pay some co-pays for particular services. And so all of those three things, out-of-pocket costs, um, more eligibility checks, and work requirements are all going to depress enrollment because it just makes it harder for people to get enrolled and it makes it harder for people to stay enrolled because they have to do more to show that they qualify and then they have to do more often to show that they still qualify. And so that those 52,000 adults, they're just low income adults. They're 19 to 64. And for a household of one, they can make as much as about $21,000 a year. Um, all of those additional requirements are going to be put in place for them. And that's going to become applicable at the beginning of next year. So a lot of people are going to lose their coverage. We know historically from other states and New Hampshire too, who have tried to have work requirements before that anything extra that we put in front of enrollment and eligibility makes it harder. Any more additional steps makes it harder for people to get enrolled and stay enrolled. And the last time New Hampshire did work requirements, which was, it got approved, and I believe 2017 and then implemented in 2019. Um, about a third of the people that were required to demonstrate work requirements um, were were scheduled to lose their coverage, not because they weren't working, but because the reporting requirements to prove that you were working were so difficult to meet that they just couldn't. That's what people are, I think, really working on right now. The state is working on trying to develop the systems for implementing those work requirements and the out-of-pocket costs and the double eligibility checks. And at the same time as that's happening, there was some extra financial help um, that was available for people who had to buy their own coverage on the individual market and got financial help through the ACA and Obamacare, healthcare.gov. That extra help expired at the end of last year. And so there's a whole other group of people about the same size, like another 50, 60,000 people who are losing access to additional financial help, which is also going to, for some of those folks, um, make it harder for them because they won't be able to afford it to stay enrolled. And so there's a lot of downstream pressure happening, and people will be effectively um, losing coverage. Oh, and we've started to see that a little bit this year because of that financial help going away. But then next year, with those additional Medicaid requirements, we'll see more.
That is significant. And that it's important that we get that word out there and that folks be aware of what's going on. Um,
Yeah, yeah, absolutely.
so Sam, let me ask you, I know you've worked with the Medicaid Matters Coalition. What are you hearing from communities across the state, and how are groups like Medicaid Matters responding to these challenges?
Yeah, thanks for the question, Jime. So I would describe the New Hampshire Medicaid Matters as a collection of concerned stakeholders here in New Hampshire. And that includes national and local advocacy groups, provider groups, FQHCs, long-term care organizations, and many others. And I think the motivation of the group is to get together, to band together and speak with one voice on Medicaid, especially in light of the cuts that Deb was just mentioning that we saw in 2025 at the federal and state level. So the group's work has been sort of divided into some different buckets. We have an advocacy bucket, that team is focused on advocating for stronger Medicaid coverage through legislation. We have a data team who's using existing data to sort of highlight the issues for decision makers and for communities. And we have a communications team who's really spreading the message and the awareness on why Medicaid matters and also just about the group's work. Most recently, we've been going around the state to hold community conversations to inform Granite Staters about Medicaid changes, what's happening. We've had some great speakers to really bring those messages to the communities, including Deb Fournier. The next meeting, I do want to make a plug. It's on Monday, May 18th, and it's going to be at the New Hampshire Food Bank in Manchester. Anyone interested can register at www.nhneedsmedicaid.com. So yeah, John, to answer your question, I would say the Medicaid Matters team has been working together to make sure that when decisions are being made about Medicaid, as they're continually made, at the state level as we speak, the people and the communities who depend on it are informed, and they're also at the forefront of these conversations with decision makers.
Well, thank you. I mean, I think it matters that you're part of this effort. It's important to get the word out. It's important to inform people. Dr. Ramas, good to see you. I wanted to ask you, from the provider perspective, I know we here have talked a lot about the impact on rural healthcare, but these potential cuts, sorry, not potential anymore, these cuts are going to have an impact on urban populations as well, and urban hospitals and health centers in places like Manchester, where consolidation is already a significant factor. Tell us what you see from that perspective.
Thanks, Jime. I want to bring up a couple of perspectives here as it relates to physicians and other healthcare clinicians in the state. One, Medicaid helped to increase access to care, but it also helped to create reimbursement for the care that was already being provided for patients. So I'd like our listeners to understand that your doctors are always going to be there. We haven't left. The difference, though, is that just like you are being asked to do more with less with these cuts, your doctors and your other healthcare professionals are also being required to do much more with less. So the impact on physicians and for clinicians in the state is already putting a tax on folks that don't have a lot of time to take care of patients, but then also as a primary care physician, the ability to send patients to specialist colleagues and coordinate care is going to be that much more difficult. With the consolidation that's happening, consolidation meaning that there are larger hospital systems that are taking a larger footprint in different areas of the state. This is also going to create strain as far as access to care and how we can provide a level of service for patients. I have a patient who has been on Medicaid, has been taking insulin, and was able to actually get a continuous glucose monitor. So instead of having to prick their finger every day, 4 times a day, they had a device that could check their sugars at any point in time throughout the day. That person, before COVID, had uncontrolled sugars, was in and out of the hospital all the time. This person is now well controlled with their diabetes. Under the current changes, they're going to lose their insurance. They're going to have to pay out of pocket hundreds of dollars a week for their insulin care, as well as the syringes and the needles. And they're going to lose access to this monitor, which means that this person who has now been well controlled for over 5 years is going to end up in the hospital. That is not the fault of myself as a clinician. That's not the fault of the patient. That is a system issue. That is a policy issue.
It is. And that's just one story, right? I mean, there's a dozen more out there like that. People who are not renewing prescriptions because they can't afford to, or taking half a dosage because that's all they can do, or hesitant to go see a doctor because they don't know what it's going to cost or to get a test. As people lose coverage, they lose that peace of mind. Although we know even with coverage, sometimes the expenses can eat you up. Thank you. I'm going to open up this next set of questions to anybody, so feel free to jump in. I'm going to start with the harsh reality of Medicaid in rural New Hampshire, places like Coas County, which are beautiful and obviously have very seasonal economies, from camping to skiing to summer visits. We know there that roughly 1 in 5 residents of Coas County depend on Medicaid, right? And in places like Berlin, it's closer to 30%. We know that the hospitals in Coas County have been struggling, and there's been a lot written about them recently. So, as we see these drops in coverage, what does the road ahead look like as funding becomes less stable? Anybody who has an opinion, please feel free to jump in. And you can all jump in one at a time too. It's not just for one person. Deb, you want to start?
Sure. So you're absolutely right that our rural counties have significant percentages of their population enrolled in Medicaid. And so Coas County, it is over 20% of the population is enrolled in Medicaid. Sullivan County is really close to that. It's about 18%. Belknap, Cheshire, really close to that, like 16%. So, the reach of Medicaid is really strong in New Hampshire and serves our rural regions at a higher percentage, a higher rate even than our more densely populated regions. And what's going to happen so there's not like a special hospital where only the Medicaid folks go, and there's not So those rural critical access hospitals and those smaller hospitals in those rural regions actually are often very efficient, but really rely on those Medicaid dollars. Medicaid is a significant payer for them, in addition to commercial payers and in addition to Medicare. And so they're going to be really, as Dr. Ramas was saying, the people are still going to go when they need to go to those places. They're going to show up later and they're going to be sicker, which means they're also going to require more services, all of that, and they're not going to have a consistent reimbursement stream attached to them anymore. So people are going to show up sicker at those same places, and those same providers are going to have to still not will still provide care because that's what they do. They're providers, but they're going to be asked to do it with a lot less dollars. And that's also going to be happening to a certain extent on the commercial side because of those other changes that happened. So the rural hospitals are going to really be faced with how do you do more with less when you're already running a really, like they're really aware of what their costs are, what their revenue is, right? Um, how are they going to do more with less when there's no more fat for them to burn?
They're going to have to do less with less, and that's the problem.
How do you make
Sam,
that
Marie,
choice, right?
anything to add, either of you?
The additional thing I'll add on top of what Deb mentioned is I want folks to understand that the average Granite Stater either has Medicaid or Medicare. If we're going to look at the numbers, this isn't a group of individuals who are lazy, who don't want to pay for, an honest day's wage. These are working individuals, sometimes small business owners, and folks that just, missed the mark, right, when it comes to being able to make enough to pay for themselves. And this is under a context of the average New Hampshire resident missing out on at least $1,000 a month just to make ends meet. So we're adding a couple $1 billion. That sounds like a lot of money, but that's in the context of losing trillions of dollars, trillions with a T of dollars when it comes to making sure that folks have access. The other thing I want to share is that we already have a physician shortage in our rural areas of the state. It is that much more, to Deb's point. And so this is not going to help with recruiting and retaining the talent, the expertise, and the skill that's needed to take care of already complex and aging patients.
Yeah, John, sorry, I'll jump in really quickly as well. I just want to echo what Deb and Maria, Dr. Ramos have said. The only thing I'd add on as well is speaking to the eventualities Deb mentioned. One potential one that's very much potentially down the road is that the fact that revenue loss often means service cuts, right? And we've seen this in the context of hospital consolidation. It's a very potential outcome with healthcare losses here. These hospitals are going to have to spread the loss from these lost federal dollars, and that can mean reduced hours, fewer specialists, longer waits, and I think critically, as we've seen through consolidation, the closure of low volume essential services like maternity care and behavioral health care. I think if we're talking about the North Country, especially, one knock-on effect is going to be the travel burden and access burden. Patients in the North Country already travel long distances, and this could mean an extra hour or more for people on the road. I think that's particularly challenging for older adults, people with disabilities, or people who just don't have reliable transportation. I think as Dr. Ramos and Deb have both said, that means people may just go without care.
And that's a very scary perspective. It also, we have to look at the economic development side. It's hard to promote people investing in the Monadnock region or the Lakes region or the North Country if there's not maternity care, if there's not stable health care, if there's a shortage of physicians. So, Maria, I think you kind of hinted at this. I just want to bridge next to the Go North initiative. I heard a presentation last night. It was very interesting. There's some major infrastructure, workforce, sustainability investment that's going to be coming to New Hampshire over the next 5 years. If all goes well, they're able to spend the money effectively. But you know what there isn't any clarity around is coverage and enrollment. And so I know these pieces connect, but what does it mean for the financial stability of providers in our healthcare system if we're investing a lot of good money on facilities and on physicians and on primary care and on sustainability, but not investing in enrollment and coverage and supports? And again, I'll open that to anybody who has an opinion because I'd like to hear. This is an important story. I'd like to hear how you connect or disconnect the dots.
Yeah, I think this is falling short. The Medical Society obviously is a strong supporter of primary care and workforce. It's obviously something that New Hampshire has needed to focus on for quite a while. But you can't open a path in a way for workforce and then not pay them. That's like saying we're inviting you to dinner, but you have to make the supper. You can make the table, right? Oh, and by the way, you're cleaning up all the mess on top of that. That's not a really great proposition. To keep new talent, we have an Ivy League school in the state of New Hampshire that hundreds of new physicians, nurses in the state, they can't stay. On top of that, you've got folks that have hundreds of thousands of dollars of debt. And so again, you're asking folks to come to a place where they want to do good, but you can't do good without the resources that you need. And you can't do good if you don't have the support for the patients themselves. So I want our folks to understand that nuance. You can't just increase the opportunity without increasing the capacity to take advantage of that opportunity. That is that's going to negate any kind of effects that can really happen. The second thing, Jaime, that I want to highlight, and I want to make sure that our listeners understand this: the Medical Society represents about 3,000 physicians in the state. Physicians want to be present, and physicians are also human. We cannot just create a resource like a nutritionist or an endocrinologist or a behavioral health therapist, you name it. We can't just make that happen because of our medical degrees. We need to be able to work in a system that is going to support the necessary ingredients to create healthy communities. The third thing I want to highlight is that Medicaid is not a gift and is not a charity. Medicaid and the allowance of increasing access to Medicaid has demonstrated in New Hampshire that it is actually a financial investment for the state. Our state is hemorrhaging per capita compared to other states in the country. We are hemorrhaging from cost of care. Too much unnecessary cost of care. We're catching folks too late. And guess what? We are the second oldest state per capita in the country. It's only going to get more demanding. So we have to stop thinking about Medicaid as those people. Medicaid is an investment to reduce cost of care. It is a fiscal responsibility for our hard workers in the state to be able to get the health that they need and therefore be even better contributors. This is what the numbers show. And if physicians are able to have that kind of access for their patients, guess what? Your patients get healthier and they're happier too. I guess it's a good secondary that your doctors and your clinicians are also healthier and happier as well.
Thank you.
And,
Thank
and,
you very much.
and
Yes.
just to put some more numbers, to put some context on what Dr. Ramas has just finished saying, um, at, at the federal level, these changes that we talked about in Medicaid cost almost $1 trillion. But the initiative that Jaime, you were talking about, um, is a positive contribution for the whole country of $50 billion. There's no way, like those are very different. They're enormous figures, first of all.
Yes.
But even $50 billion pumped into things like you were saying, modifications and improvement in workforce and primary care access, and all of those things are tremendously positive. But 50 billion does not equal 1 trillion. Like and the system can't magically come up with it. So it's just a harsh reality that really positive things that the Rural Health Transformation Fund can promote, um, cannot replace um, the resources that are being drawn out of the Medicaid program. And also to Dr. Ramos's point about Medicaid being an economic engine. Um, the Medicaid expansion is that 52,000 group of people, the Granite Advantage folks, who are getting most of these enrollment frustrations policies that are coming for them. Because of the way that the finances are structured, that population, 52,000 people, has since it became available in New Hampshire, has brought in over $3 billion into New Hampshire's economy, $3 billion federal dollars, right? So those are dollars we did not have and that we did not produce, have come into New Hampshire through the Medicaid program. And that's just one example of the way in which Medicaid as Dr. Ramos was saying, is an economic investment, is an economic engine to help support New Hampshire. The vast majority of those dollars for that group are federal dollars, which is why it's been such an amazing initiative for New Hampshire to invest in, because it's just making really smart use of available federal dollars for Granite Staters, right? For just regular people um, who are working hard and trying to do their best.
And at the same time, supporting our medical infrastructure, which is very important.
Absolutely.
Already
Like,
kind of shaky, so
I mean,
that
well, and
money
we were
really.
talking about those rural hospitals,
Yep, I
right?
know
They're
that you
great
should.
employers. They're great,
Yeah,
community
yeah,
members. People are understandably and intensely proud when they have a local hospital in their region, right?
absolutely.
And so absolutely, it goes to support those facilities and all of the other, like the little diner that supports
Yep,
the hospital staff, all of that stuff, like
yep,
it is interconnected inextricably.
yep. I know a lot of high school kids who work part-time at Concord Hospital and make money. Sam, as we're running up against the hour, I want to give you the final chance to, if you have anything else to say, and then we'll go to media questions. Sam, you got anything to add? You're going to close this off with the golden thought.
A golden thought, no pressure.
No, no, no.
I think John, one thing you brought up before was what to look out for, and I'll keep it short. And I think what we should be looking out for in the next 6 months to a year is, I think, two things at the same time. Are fewer Granite Staters going to be covered? I think the answer is yes, but I think that's yet to be seen. I think it's certainly one of the canaries in the coal mine that we're going to be seeing about how these cuts are going to be affecting Granite Staters. And I think the second thing we need to keep our eye out for are more rural services closing or shrinking. I think likewise, that's going to be a good indicator for where we're headed. If the answers to both of these questions is yes, I think we're not transforming rural health. We're hollowing it out to some extent. So I think as Dr. Ramos and Deb said, these new infusions of cash in New Hampshire and into rural communities is fantastic. But if we're not increasing coverage alongside that, if we're not putting more into our rural services and our providers, then we're not making enough of a difference in our rural communities.
That is a good thought, and thank you. I'm going to ask my colleague Rachel to come join us, see if we have any questions from the media who has joined us or who have joined us, I can think. Hi, Rachel.
Thank you, Jime, and thank you everyone for joining us today. I will open the floor for press now. If any of our press on today's call have any questions for us, I invite you to put those in the Q&A box at the bottom of your screen. And if you have a question for a particular speaker, to please note that in your question. We have a question submitted ahead of time. I will have this open to the floor. And that is, what can New Hampshire elected officials do to protect Medicaid and mitigate the harm that will result from the cuts in the One Big Beautiful Bill?
So I'm going to go first. I'm sure I won't be the only person that speaks. The work requirements, the community, they're referred to as community engagement requirements that are coming for the Granite Advantage or expansion population. They can be really complex to implement, and a way to mitigate the loss of coverage that everyone anticipates will happen because of the work requirements would be investment in some type of community engagement navigation services, people that get trained in what is required to demonstrate that people are complying with the work requirement, or that they are exempt from the work requirement, and having those people trained and on the ground and ready to go January 1st is a very practical, direct way that New Hampshire could choose to mitigate some of these losses, because it will help people participate and simply document that they are eligible and that they are fulfilling these requirements. So that's the first thing that comes to mind for me.
I'll just add as well that it is imperative for our policymakers to define what is success. Just infusing money into a system is not an objective way, as a physician scientist, is not an objective way to identify success. And so whether that mean shorter wait times for primary care visits or decreased cost of care, which we are clearly focusing on, or are there particular demographics of people within the regions of the Granite State that are affected differently? Those are, I think, smart questions that the Medical Society, the Institute for Health Policy, New Futures, and other stakeholders would be able to help you craft. The second thing is to make sure that we're not affecting in a negative way the clinicians from a cost reimbursement standpoint or quality measure standpoint for the care that they are giving, if our patients are not getting the access that they need. So I should not necessarily be adversely affected if I have my patient that will no longer be controlled with diabetes, and now I cannot get paid with these same patients that are available on Medicaid because they lack access. That is going to increase administrivia to our clinicians, which will increase burnout. And administrative burden is the number one reason why clinicians and physicians alike step out of practice. So we want to make sure we guard ourselves from unintended consequences.
Well, thank you. And I want to say thank you all for your thoughts on this Medicaid Awareness Month and for the work that you're doing on behalf of patients and communities across our state. This is a complex moment, but it's an important one The decisions that are being made now will shape access to care across New Hampshire for a generation to come. So thank you on behalf of Protective Care. We appreciate everyone joining us today and for being part of this ongoing conversation. I know we're going to keep talking, so thank you.